I'm peeing acid in my urine, and then of course I'm dehydrated, right? Okay? Okay, so what we are saying is that I am vomiting chloride, so I become hypochloremic. I am vomiting hydrogen ions, I get metabolic acidosis. Now I have to pee out I need to pee out my alkali. I'm going to pee out sodium bicarbonate. I'm losing sodium now. A point comes when losing sodium with so much of water with it, and the vomiting amount is not much in the vomiting of a small baby. So now with losing so much of sodium in my urine with that water, I now start to get dehydrated. So now my aldosterone kicks in. When my aldosterone system kicks in, what it says is that I cannot let you use sodium anymore. I need to pick up sodium. Sodium has to be exchanged with something. So when they pick up sodium, sodium is exchanged with potassium. So in alkalosis, potassium goes into the cell, plus I am now losing potassium in my urine. Then a critical period comes when potassium goes down to around 2.5 or so. At that time, the brain tells the kidney, stop, you can't lose any more potassium. Now you have to exchange it with hydrogen ions. So now what is happening, though I have an alkalotic state, I am actually exchanging my sodium with hydrogen ions. Is the word called paradoxical aciduria, and it suggests that not only I am hypokalemic, I am dehydrated. So once you get something like this, you say, hydration, there is no rush to take you to the OR. I need to correct your dehydration. I need to correct your potassium before I'll take you anywhere else. So that is that kind of a thing that should be in the back of your head when you notice something like that. Now we come to this part where we love, we do this a lot. When persistent vomiting results in treatment failure, IV therapy is required. So IV therapy, we do two things. We do traditional versus rapid versus ultra rapid. Then to use saline with or without dextrose. And then for maintenance, trying to push that, we should probably use an isotonic with dextrose and not use hypotonic solution anymore. So we grew up with traditional, it is not practiced anymore. So what was a traditional way of doing it is that I'm going to calculate how much you are dehydrated. I am going to give you maybe first 10-20 cc per kilo in an hour or so. Then I'm going to space the next half over 4 to 6 hours. Then I'm going to give rest over 8 hours kind of a thing. We have moved away a long time ago. That's not practiced anymore. So replacement of fluids and electrolytes for long periods ranging from 24 to 48 hours. Problem was proton therapy sometimes led to persistence of symptoms, discomfort of child, and a prolonged hospital stay. And as our ED started to get more crowded, we gave up on this. And then we came up with something called rapid or ultra rapid hydration, right? So benefit is faster administration to ED discharge. And the challenge was that people practice it very different, wide variability in volume, infusion rate, composition, and each ED seems to have a different guidelines on how to do it. I don't have a set guidelines at UHP. Do we have one at KCHC? No, we don't, right? So when we're going to use the word ultra rapid or rapid, the other word now, because the traditional is gone, some people like to use the rapid, the word is standard, because a rapid is now the standard of care. So we should know what the rapid is all about, right? And there is an update here that I wrote down also. So ultra rapid is giving 50 ml per kilo or 1 hour. And where does this number come from? We say that if I was to bleed our dear chief here, I'm going to get 5 liters of blood from her. If I'm going to bleed her, I'm going to get 5 liters from her too. And so from him, I'm going back and forth, right? Because general concept is an adult is 70 kilos, you have 70 cc per kilo, automatically I will drain 4.9 liters out of you, right? So the same concept in kids, you have 70 to 80 cc per kilo. If I'm going to give you 50 ml per kilo, essentially I'm almost totally replacing 3/4 to full of your circulating volume. So if you are dehydrated and I give you so much of volume, presuming that you're isonatremic, you should get better in an hour and go home in 2 hours, right? And so the crowded ED, go home quickly. So that is why people do practice something called as ultra rapid. And rapid is the way to go with the standard of care for almost like 6, 7, 8 years now. This is not something, a new concept I'm teaching. some people may not be aware of it. Intravenous rehydration with 20 ml per kilo hour by hour of 0.9% saline solution for 2 to 4 hours, followed by resumption of oral hydration or continuous infusion of dextrose containing solution and maintenance rate. This is given. This is what we have been practicing so long. I don't see that in practice but this is how it should be practiced. And this is standard of care. So, structured question. In children with dehydration secondary to gastroenteritis, which is the patient, does ultra-rapid intravenous rehydration offer a more effective intervention compared with standard or rapid method of hydration, right? If you go back and look at, so people who went back and did reviews and collected all these articles, really only two stand out, unfortunately, that they could talk about something. So, first is this one. 88 pediatric patients, ages 3 to 36 months, treated in emergency department, moderate dehydration. Single center randomized control, single center blinded randomized control for this one. 3 to 36 months, 3 months to 11 years. Ultra rapid, 50 ml per kilo or 1 hour versus they gave almost 17 cc per kilo per hour, almost close to that with normal saline. This one gave also rapid 60 ml per kilo versus standard 20 ml per kilo per hour for 1 hour only. Now they did it only 1 hour, 1 hour. So as I said, it's all over the place. Prime and here no outcome measures were clearly defined. Here they looked at the end of 2 hours state of rehydration, and secondary outcome was prolonged treatment, scores on clinical dehydration, adequate oral hydration time, and if they came back within 72 hours. In this group that compared 1 to 3 hours, all ultra subjects discharged 2 hours from the onset of study, all standard discharged at 4 hours as it was planned. Pilot study looking for intervention to show equivalence to standard treatment, no significant complications occurred, but was not powered to assess safety, so it's so difficult. Over here, if you look at 36 on the rapid versus 36 in the ultra rapid and 29 in the rapid were rehydrated at 2 hours. But look at the secondary outcome, more children in the ultra rapid group admitted versus, and the time to discharge was also higher in the one that got 50 ml per kilo. And the idea was that giving you so much of fluid and so much of chloride, maybe it is the hyperchloremic metabolic acidosis that I'm creating, is making them go home later. That came out of these two. I'll break it down a little more. So the first one was a USA study, 1 hour versus 3 hours. Look at the amount of MSs and urine volume. You can't say because this is in only 1 hour, this was over 3 hours. Urine specific gravity. Return rate, 7 in 1 hour group. 6 hydrated by oral hydration, 1 with IV, all went home. 6 in the 3 hour group, 5 treated by oral hydration, 1 with IV, all went home. In the Canadian study, the second one, they found that ED length of stay was greater than 6 hours in the ultra rapid one versus 33%. And the revisit rate also was higher, 6% in the ultra one versus 5% in the rapid one. This was surprising. Overhydration occurred in 4 of the rapid one versus only 2 of the ultra rapid one, which is kind of odd, but that's what was there. If you look at the outcome that I wanted to show, is that look at the successful rehydration, no difference in complication, except that the return revisit is higher for the rapid ultra in both the group. That was the only thing. That was it. So really, again, they were not powered for that. There was no rationale to check this. But that study just says that it's not superior over the regular one we practice. Hyperchloremic metabolic acidosis may be a concern. But some still ED prefer this. I can give you an hour, send you home, and you can go home and you'll be fine. So it all depends what the ED like. So I did not find that because of this, and because they definitely had a delayed discharge in the rapid group, and the difference was about 2% in the people who got admitted more or came back. So I like this, that there's no superiority of the ultra rapid over rapid hydration. Idea is to feed this thing, put a seed in your mind that there is something called like this. Go home and read about it. And when you grow up, you say, I'm going to do it this way or this way. But right now, I still think that the rapid, which is 20 cc per kilo per hour by hour for 3 to 4 hours, is the right way to go.
Do you like to start with dextrose-containing solutions or do them after initial bolus?
So that is the 5th slide from now. I'll give you my preference. There's not much literature out there, but we'll talk about that. Now maintenance fluid. So we grew up saying that your requirement of sodium is 2 to 3 milliequivalents per kilo per day. So if you are a 10 kilo kid, your daily requirement is 30 milliequivalents of sodium. So I have to give you 30 milliequivalents because my requirement of free water is 100 cc per kilo per day and I need a liter of fluid in 24 hours. That means my solution should contain 30 milliequivalents of sodium in 1 liter. Does that make sense? And that 30 milliequivalents per liter is called 0.18% or 1/5 saline. That's where the concept came from. And the concept came from in 1957 based on healthy children and use of sodium content in human breast milk, cow milk as a guide for daily maintenance requirement. This is going back even before I was born. Thus, IV fluid for children contain what we call as 30 millimole per liter. That's how it all started many, many moons ago. Fast forward, in 2012, Healthcare Product Agency and National Safety Agency issued alerts of high rates of seizures, cerebral edema, and death due to hypotonic fluid prescriptions. And they came out suggesting that isotonic solutions such as 0.9 saline with 5% dextrose. Now remember, this is not bolus. This is maintenance we are talking about. That means I have tanked you up, and now I'm just giving you maintenance that you require. As compared to that, in the last 3 years, actually there's only one systematic review and 3 trials that have been published to address something like this. I know it's a very busy slide, but take it from me that if you look at it, all of these, and they tried plasma light versus sodium, and they tried 0.9 with 0.8 and 4.5. End of the result was that other than 0.9, every of this group developed hyponatremia when given maintenance fluid which was not isotonic. Now why is the problem? The problem, I think, that we are admitting more sicker patients, and I think those sicker patients, be it pulmonary, be it anything else, are developing what people are calling non-osmotic ADH release, and this is now responsible for withholding free water. If I'm already giving you a lot of free water with less sodium, that is what is causing. The problem is because these severe adverse events are very uncommon occurrence. To really power a study to show that is the major problem in most of them. But the general recommendation is that the 4 studies I showed you in the past, I'm happy to share that and you can look at that, suggest that 0.9 may be the way to go. And some of the books, actually articles now say that giving 0. or 1/5 saline is actually unethical now because it really can mess things up. Again, this is something. Importantly, even when patients receive isotonic solution, there are some areas risk of hyponatremia also. One who got 0.1 one of the studies dropped his sodium to 114. But very isolated case like that even occurs. So what we're saying, even with the normal saline and the non-osmotic ADH, the problem is still there. So using a more hypertonic solution, you can just put them at a higher risk. That's why they are going away from anything else except 0.9. I'm not talking about neonates. I keep telling people the newborns are aliens. They do not belong in pediatrics. So do not hold me on that. Dr. Tejani said so. We're not talking about it. We're talking about outside that age group. Now, this was the point you're asking about, is that addition of dextrose to 0.9 saline for rapid hydration. How many of you practice, Roxanne, tell me across the street, the practice is bolusing someone with D5 and normal saline mixed together. You're done. Okay. See, I also of the idea that I would like to give you saline. If I think you have any sign and symptoms suggesting of hypoglycemia, I will check your glucose. And most of us would run a D5, D10, whatever, at 0.5 to 1 gram per kilo and give you that way. And so the logic is that as for the choice of 2.5 or 5%, it is based on the hypothesis that glucose administration aims to reduce ketonemia in children with vomiting. and to stop the vicious physiological pattern of vomiting, hypoglycemia, ketosis, vomiting. This is what you're trying to get out of, right? So at the end of the study, you want to know, if I give you this, did the ketones in the blood go down? But why do I care about the chemical part? Ask me, did the vomiting get better or not? That is the problem with most of the studies, that they have not addressed this question. They are showing me that the hydration got better, of course. My ketonemia got better, of course. But did my vomiting get better? Did my hospital admission rate got better? Did most of them go home or not? That is the problem with the study that I will go talk about it. That the problem with giving this is that once too rapid glucose is infused, it leads to surge of insulin, then causing reactive hypoglycemia that needs to be monitored for a longer period of time, because now I gave you insulin, now you're becoming hypoglycemic again. I have to give you more sugar water. That balance takes more time, so you're going to spend more time in the ED if I give you D5. Or maybe I need to admit you in a hospital because I'm not able to get a good control on this increased insulin production then. That's why people are asking the question, should I actually bolus you with dextrose or not bolus you with dextrose? And this may lengthen the total ED stay time. Surprisingly, there are only 2 articles that looked at that. The first one used a D5, the other one used a D2.5. And this is actually a good one because it actually compared sodium, saline with dextrose. This only gave 2.5%, and there's no comparison at the end of it, so whatever it's worth it. As I said, there are many studies you can go back and look at, but the main important question is the vomiting part is not addressed in most of them that you are trying to address. So this one is 83 patients. They did everything. They gave 20 ml per kilo of saline for 2 hours with 2.5% dextrose as a part of it. So 17% failed and got admitted, and of the 83% who went home, 7.2% came back with 1 requiring further hospitalization. So almost close to 20% got admitted. Of course, they talk about decreased level of ketonemia and uremia and the Gorlick scale, but they do not mention if supposedly, as I said, in their study, 20% got admitted eventually. The other one did both comparison, 20 ml per kilo with D5, and their primary outcome was the children hospitalized, and then secondary outcome was change in serum ketones. And look at that, in the first group, 35% in D5 got admitted versus 44% in normal saline. So really that's not much difference there. But of course they come back and say, yes, the ketones didn't get better, but the hospital rate was not difference at all. So they have left it upon me to decide now whether I should give or not give. I think the jury is still out on that one. I don't think there's convincing evidence of both. I don't know the right answer to that. Yes, it does help with ketonemia, but again, the rate of hospitalization is no affected. Maybe more studies on this. My practice, I'd like to make a difference, like I was telling James, that I want to know we are dehydrated versus as inability to tolerate PO, and then I correct hypoglycemia separately, and I don't know that. Yes. This is called a baby thinker. He's thinking with one eye closed. Thank you for listening and being such a great crowd. Thank you very much. Of course, there are questions. Any questions I can take. There are so many articles I went through. If anybody is literally really interested in looking for references for these, what I say, I am happy to provide you all. Whoever sends me an email, I'll just tag it along. He said first one. Yeah, go ahead.
When you correct the glucose, do you do it in boluses or you switch to glucose containing IV solution?
My fellows, he said that do you bolus glucose? If I find my glucose is 45, do you put it added on with dextrose, with saline, or you give it separately?
If the patient is symptomatic and I worry about that glucose is 20, then I bolus.
I also bolus them on separately on the side. And then, again, as I said, you have to be worried about it. Once you bolus, I think people forget that this is going to make insulin shoot up and glucose will go down. So you may want to add dextrose after that. I think so. I think that would be the way to go. Yes, sir.
What do you use for maintenance fluid for neonates?
Say again?
For neonates, maintenance fluid, what do you use?
So, as I said, less than 30 days, the issues of immature kidneys and stuff like that, I still do not use 0.18 anymore.
So you just do D5?
I do D5.45 for that age group is what I do. Above that, 3 months and older, I just give 0.9 normal saline with dextrose now. I have given up on 0.8, 1.8 in my, but again, neonates is do not, because again, you can go back, neonates are still really tough, and I can't tell you about the neonates management. That is very different management altogether.
Are you worried about giving 0.9 saline with D5, that it's hypertonic and that they still need free
People
water?
talk about that dextrose gets utilized and what you're left with is isotonic solution. So you start with something that is 0.9 D5. As glucose gets absorbed and gets metabolized, you're left with 0.9, which is
Even
an
if they're
isotonic solution.
euglycemic.
Thank you.
Thanks.